Hello.
Hello, Dr. Kamal. How are you doing?
Good. You made it. We were waiting for you.
Oh, shut the door. I just got it. So that's perfect.
Good, good. I'm glad everyone got the link. I think I'll go ahead and get started just for the
Good. Can I
interest of
introduce you?
time. Yes, please.
Hello and welcome to the Division of Geriatrics Grand Rounds. And I am thrilled to introduce Dr. Nevin Kamal, who is our geriatric medicine fellow and soon to be endocrinologist and geriatrician to the stars over at UIC. And so very proud today to introduce her, and she will be presenting on Beyond the Fingerstick, a practical approach to diabetes care in the post-acute setting. So thank you for everyone joining us, and yay, I'll pass it over to you, Dr. Kamal.
Thank you, Dr. Lindquist, for the kind words. So today, as she mentioned, I'll be presenting on practical approaches to diabetes management in post-acute settings. So this was originally a presentation I had built for the post-acute network for an audience of mostly nurses. I did adjust a little bit since then, but some of the information I kept in just for purpose of review, just because we don't think about these things often. So bear with me if there is some redundancy, but I hope that overall you'll find this helpful. So on today's agenda, I'll be going over a little bit of diabetes overview, pathophysiology, and prevalence in the post-acute setting. I'll be discussing challenges of diabetes care in post-acute facilities, explaining hypo and hyperglycemia as well as their management, provide practical tips regarding glucose monitoring, and review medications commonly used in diabetes management. And then if we have time in the end, I know we're at the 35-minute mark right now. If we do have time, I'll go over some case examples as well. So why does this matter? Diabetes is a major concern in nursing homes, with approximately 30% of residents in nursing homes and post-acute settings are having diabetes. And so management of diabetes in the setting can present some unique challenges, as you're all aware. One of the biggest concerns is the high risk of hypoglycemia. And this is due to multiple factors, for example, variable appetite, declining renal function, inconsistent physical activity levels, all of which can make glucose control unpredictable. And then additionally, on top of that, many residents have multiple chronic conditions leading to polypharmacy, complex medication interactions. And these factors increase the risk of both hypo and hyperglycemia, as well as complications like infections, falls, and cognitive decline. We also know that hospital readmission rates are significantly higher for nursing home residents with diabetes, adding to the burden on both the patients and the healthcare system altogether. And then further complicating care is staffing limitations and inconsistent glucose monitoring, which makes it even harder to maintain stable blood glucose levels. So ultimately, our goal is clear. We want to improve safety, we want to prevent complications, and we want to enhance the quality of life of our residents. So diabetes, as we know, is a chronic condition characterized by elevated blood glucose levels due to a defective insulin production, insulin action, or both. Type 1 is mostly autoimmune. It's characterized by the immune system attacking the insulin-producing beta cells in the pancreas, and then that results in an absolute insulin deficiency. So the patients are typically dependent on insulin for survival. Type 2, on the other hand, is mostly a combination of insulin resistance and progressive beta cell dysfunction, meaning that the body does not really use the insulin effectively, and then over time, insulin production does decline. So even though we don't typically start with insulin management in the beginning, generally over time patients do end up needing insulin for their management. There are also other types of diabetes that we encounter in clinical practice. That's steroid-induced diabetes or post-transplant diabetes, mostly due to medication side effects that impair glucose metabolism. Hospital-acquired hyperglycemia or stress-induced hyperglycemia, which is a transient increase in the blood glucose levels due to acute illness or psychological stress. physiological stress, excuse me, and then diabetes related to chronic pancreatitis, which results from damage to the pancreas in itself, leading to both insulin deficiency and digestive issues. So we all know in type 1, patients are very insulin dependent. So it's critical that we never stop long-acting insulin, even when the patients are having poor PO intake or are NPO. And I'll just skim through that very quickly just because it's mostly a review slide, but risking DKA if we miss insulin in type 1 diabetes. And then for type 2, as I mentioned, initially we start with oral medications, and then eventually oral meds would potentially be insufficient to control the hyperglycemia, and insulin is required. So the key goals of diabetes care in the SNF is to prevent hypoglycemia, prevent severe hyperglycemia, and we really want to avoid tight glucose control. So the way we do that is by individualizing glycemic targets. We want to minimize medication-related side effects and medication interactions, and we want to try to improve residents' quality of life and functional status. So what do I mean by individualized targets? Glycemic goals should be individualized based on the patient's overall health and life expectancy. And this is a particularly important concept in geriatric care in general. So for younger adults who are in good health with minimal treatment risks, usually a stringent target of less than 6.5% A1C is appropriate. But in older adults, typically the A1C goal is about less than 7.5%. And then for older adults with complex or intermediate health conditions, the A1C target of less than 8% and sometimes even 8.5% is generally more suitable because we need to consider their unique needs and their risks. In older adults with very complex or poor health, as well as those with a limited life expectancy, it's important to recognize that an A1C, a specific target, may not be necessary or even beneficial. Instead, we want to try to focus on a flexible approach, focusing on symptom management and quality of life more so than the numbers. So how often and how frequent do we check blood sugars in the post-acute setting? Frequency really depends on the individual regimen being used, the patient's functional status, and their overall goals of care. If we're dealing with diet-controlled diabetes, then there's really no need for checking blood glucose, and an A1C every 3 to 6 months is sufficient. For patients on oral meds such as metformin, DPP-4 inhibitors, SGLT2 inhibitors, then once or twice a week glucose checks are sufficient. And then the exception to that would be patients on sulfonylureas like glipizide, glimepiride, glyburide. For those patients, we want to do more frequent monitoring because we want to ensure the safety of these medicines due to the risk of hypoglycemia. So you want to start with, typically what the ADA recommends is you want to start with 1 to 2 times daily initially on admission, and then you can adjust the frequency based on the stability of blood glucose over time. So if you're not seeing any major fluctuations and a very minimal risk of hypoglycemia, then you can space that out to 2 or 3 times a week. For patients on basal insulin only, then once a day or sometimes twice a day glucose checks are necessary depending on the patient's risk of hypoglycemia, but once a day is typically sufficient. And then for patients on a basal bolus regimen or a sliding scale insulin, then they should have their blood glucose checked before each meal and at bedtime. And then finally, for patients on steroid therapy, then postprandial monitoring is recommended. That's really just to assess the for postprandial hyperglycemia and to see if they actually need any anti-hyperglycemic therapy. So basically, the summary of all of this is you can start with more frequent monitoring upon admission, and once you have established that blood sugars have been stable and not really fluctuating with minimal risk of hypoglycemia, then you can space out the blood sugar checks. So I wanted to take this opportunity to mention as well that CGM should not only be considered, but also encouraged in post-acute and long-term facilities. The American Diabetes Association now supports the use of CGM, and particularly for residents who are on insulin or patients who have a high risk of hypoglycemia. And this includes individuals with impaired hypoglycemic awareness or patients with cognitive decline who are unable to report symptoms of hypoglycemia. Importantly, the device selection needs to be personalized, accounting for each patient's clinical complexity and their functional capacity, as well as their ability to use technology or learn how to use it. And the ADA also emphasizes that safe implementation hinges on, robust staff education and a standardized facility protocol to guide the usage of the devices. It's probably much easier to just continue the use of CGM on someone who has already been using it before their admission, rather than just starting one altogether from scratch in the facility. And this ADA recommendation is a significant shift from prior recommendations, which reflects, the growing role of technology in improving inpatient and post-acute diabetes management. A recent randomized controlled trial in long-term facilities directly compared real-time CGM to the traditional point-of-care glucose monitoring for insulin dosing in residents with type 2 diabetes, and the outcomes were very reassuring. CGM provided equivalent time in range and mean glucose levels with no increase in the hypoglycemia risk. And these findings really demonstrate that CGM is not only safe, but it's also feasible for institutionalized older adults. While the American Medical Directors Association, now called, or AMDA, now called PALTC, it doesn't explicitly recommend CGM yet. It does support individualized glucose monitoring strategies, making CGM a reasonable option when appropriately integrated with staff workflow and care plans. So why do we care so much about hypoglycemia? As I mentioned before, older adults are generally at a higher risk of hypoglycemia due to their multiple comorbidities, decreased renal function, variable oral intake, cognitive dysfunction, and amongst other reasons. Unfortunately, hypoglycemic events in nursing homes are not uncommon, and they're associated with increased emergency room visits, hospitalizations, higher mortality rates. Even a retrospective 1-year study conducted in multiple SNFs in the Cleveland area showed that 38% of residents experienced an episode of hypoglycemia, and 33.5% of them experienced severe hypoglycemia. And in another observational study in long-term care facilities, 35% of residents with type 2 diabetes experience hypoglycemia annually. Imagine 35% annually had an experience of hypoglycemia, and a whopping 25% of residents experience severe hypoglycemia with a blood glucose less than 55. So events are generally more common in individuals on insulin and sulfonylurea, which are associated with hypoglycemia. But overall, the statistics highlight that the significance, prevalence, and the impact of hypoglycemia in nursing homes and post-acute care settings. And this underlines the need for really vigilant monitoring and tailored diabetes strategies. So recognizing hypoglycemia cannot always be straightforward, especially when we're dealing with cognitive decline and masked symptoms, especially with individuals on beta blockers. So we should have always a high clinical suspicion and always stay vigilant for the usual symptoms: the sweating, confusion, tremors, dizziness, weakness, and blurry vision. And we should always also suspect it even in patients without diabetes, as hypoglycemia can still occur in non-diabetic patients, particularly in the context of acute infections and sepsis. If the patient is awake, the way you treat it is with 15 grams of fast-acting carbohydrates. That's in the form of juice or sugared ginger ale. And then keep rechecking the blood sugar every 15 minutes until the hypoglycemia resolves. And if the patient is unresponsive, then we'll have to use a glucagon injection, or if we have IV access, dextrose. So key strategies to prevent hypoglycemia include adjusting insulin based on appetite and oral intake. We want to try to avoid using sliding scale on its own, and I'll go over that in a few slides. So we want to use both basal and prandial insulin for better glucose control in comparison to just sliding scale on its own. And then for those on long-acting insulin, sometimes a bedtime snack can help prevent fasting hypoglycemia. And then we also need to monitor renal functions closely because a lot of medications need to be adjusted in the event of renal dysfunction, namely sulfonylureas, and we want to try to even discontinue them if there is renal impairment, as well as insulin. In frail patients, we want to try to deprescribe as much as possible to minimize their risk. And again, CGM is a very valuable tool, especially in this setting, as it detects early hypoglycemia and alarms to the patient and the caregiver before the hypoglycemia occurs. Studies even showed that CGMs can detect hypoglycemia in about 80% of older institutionalized patients and severe hypoglycemia in about 45%. Now, it's important to also recognize that hyperglycemia is not just a number. It has clinical consequences, especially in older adults. If the blood sugars are persistently elevated, then we're increasing risk of infection, leading to more frequent ED visits and hospitalizations. It also contributes to poor wound healing, making recovery from injuries or pressure ulcers or surgeries more challenging. And in addition to all of that, hyperglycemia itself can cause dehydration and electrolyte imbalances, which can lead to weakness, confusion, increased risk of falls, among other problems. So it's also a key contributor to urinary incontinence in skilled nursing facilities, which can significantly impact quality of life. So, what might cause hyperglycemia? Either missed medications or under treatment, infections, steroids, stress, dehydration. The residents can usually present with polyuria, polydipsia, but it is also common that they are asymptomatic, especially in long term untreated diabetes. And then we always need to stay vigilant for signs of DKA or HHS. So this is just another review slide for how to manage severe hyperglycemia. We want to check ketones, especially if there's type 1 diabetes or if the blood sugar is higher than 300. You want to review and assess the underlying causes. Is it a missed dose, infection, steroids? If the blood sugar is below the 300 range, you want to try to encourage fluids, water, specifically as much as possible, avoid simple carbs, and repeat a blood sugar check in a couple hours. If the blood sugar is above 300, then you want to consider a dose of sliding scale. So these are the next few slides are really practical tips specific for not just post-acute care settings, but in geriatric care in general. First, it's important to remember to, educate our colleagues, especially nursing staff in the nursing homes when we are able, because for nursing staff, proper timing of the blood glucose check and the insulin administration is very crucial to prevent fluctuations in the blood sugar and to ensure safety. Mismatched insulin timing and meals can lead to really dangerous sugar swings. And if the insulin is given too early, for example, hypoglycemia can occur before the food becomes available. And if the insulin is given too late, then hyperglycemia can occur due to the food being absorbed in the absence of insulin. And then this can later be followed by hypoglycemia once the insulin is absorbed and kicks in, but the food has already been processed and digested. So it's very important to emphasize the proper timing, which we will go over shortly. And in general, delayed and missed meals can be particularly risky for patients specifically on insulin and sulfonylureas. So when is the right time to check the blood sugar? This depends again on the regimen and the individualized risk of hypoglycemia. If the resident is on a basal bolus insulin regimen, they should have their sugar checked 4 times a day. And this includes fasting blood sugar before breakfast and then before each meal. And this helps assess the overall glucose control overnight. So if the patient is on basal insulin, then the fasting blood sugar in the morning can give you a rough indication of whether or not the basal insulin dose is appropriate or needs to be adjusted. Um, then before each subsequent meal throughout the day, this should be done about 15 to 13 minutes before the patient starts eating, and this will guide the mealtime insulin dose and prevent hypoglycemia. Then one more blood sugar check before bedtime, just before sleep, and this helps prevent overnight hypoglycemia and guides the dosing of the basal insulin that is usually given at night. Sometimes post-meal glucose is also done. That's done typically 2 hours after a meal, and it's only needed in certain scenarios to help assess the efficacy of oral medication. So, for example, if someone is on a sulfonylurea before meals or with meals, then you can check a postprandial sugar 2 hours after the meal to assess the efficacy of the medication. Of course, additional checks should also occur whenever there's a concern for hyper or hypoglycemia um, from like the signs and symptoms we discussed. So, when is the proper timing of insulin administration? To answer this question, we should familiarize ourselves with this graph here that shows the different types of insulin and their insulin action over time. So, first in green, the first one on the left, this is short time or mealtime insulin. That's your Lispro, Aspart, Novolog, or Humalog. The onset of this insulin is typically within 5 to 10 minutes of injection. It peaks at about 30 to 90 minutes, and its activity resolves after 4 or 5 hours in reduced renal function. This really mimics the effects of food on blood sugar in terms of timing, and that's why that's our go-to insulin for meals. So practically speaking, you want to administer the dose about 15 minutes before the meal, such that it kicks in by the time the patient starts eating and then peaks at the time that the patient is done eating and the food is being absorbed maximally. If the patient is not eating or has a very poor appetite or minimal oral intake, then we have to hold the mealtime insulin. And if the patient is, if the meal tray is delayed or anything like that, then you want to hold the dose until the tray arrives. Next, in red, we have short-acting regular insulin. Um, and then in blue, in intermediate acting NPH. We typically don't really use these anymore in outpatient diabetes management since their action graphs do not really mimic glycemic trends in response to meals. However, we do use NPH in certain scenarios, such as with prednisone. That's because the peak action and the whole like duration of action of NPH really mimics the effect of prednisone on blood sugar rises throughout the day. So if you give prednisone and NPH together in the morning, the NPH will kick in by lunchtime, which is actually the meal that it gets affected most during the day with postprandial hyperglycemia. In pink, last one here, we see basal insulin, long-acting insulin. That's your Glargine, Lantus, Detamir, Degludec, and Tresiba. These insulins don't usually have a peak. Their onset of action or the action time lasts for about 24 hours. So we try to aim to administer this dose at the same time every day, either every morning or every night. And technically speaking, we don't necessarily need to hold it when patients are NPO because this is the insulin that just works on background hepatic gluconeogenesis control and not really associated with food. You may run into mixed insulin sometimes in certain patients, like 70/30 NPH regular. They're less commonly used, but sometimes certain patients are on them just due to being on them for many years or due to insurance coverage. These insulins in particular have to be given 30 minutes before the meal instead of 15 minutes. So I think it's good to know that just for practical applications in the SNF. Sliding scale insulin, in general, is a very reactive approach to blood sugar management, and it's not proactive. So it often leads to frequent fluctuations in the blood sugar. You get a very high hyperglycemia, and you correct it, you can get low hypoglycemia. So you still get a lot of risk with using it, especially risks of hypoglycemia. And because it's a reactive approach, you still get all the bad long-term effects of hyperglycemia. So um, we don't usually recommend using it, especially not on its own, because it does not prevent the high blood sugar, um, and it carries a risk of low blood sugar. So if we do want to use it, there are certain uses, good uses for it short term, like post surgery when there's physiological stress, and it's going to be short lived. When there's an infection, same application, or when we're using steroids for a short period of time. It can also be helpful when there's inconsistent and unpredictable oral intake, especially in patients with advanced dementia. And then if we use it, it's better to be used with a background basal insulin rather than on its own. So I wanted to just go over commonly used diabetes medications so we're all familiar with their typical side effect profiles. Metformin is typically associated with GI side effects, as we all know. We want to be cautious with renal function and discontinue if the GFR is less than 30, and avoid starting it altogether if GFR is around 45 or less. Sulfonylureas, I think we all do a good job at trying to discontinuing them whenever we can because of their high hypoglycemia risk. DPP4s are generally very well tolerated. They're also weight neutral. They're not very strong. They typically decrease A1C by about a half percent, if even. So they're usually used in combination with other meds, but they're very well tolerated. GLP-1 receptor agonists, as we all know, can cause nausea, poor appetite, GI side effects, dehydration. So we should use them very cautiously, but they're helpful when weight loss is desired. Basal insulin is typically safer, as I mentioned, safer than using sliding scale on its own. And if we see someone on a sliding scale on its own, we want to try to transition them to a scheduled dosing with meals. When we notice declining renal function on labs, our first step in terms of insulin adjustment would be to reduce their doses by about 25%. If there's a poor appetite or the patient is not eating, we want to hold mealtime insulin. If we're starting new steroid therapy, then we want to increase their prandial doses. If they're not already on prandial doses, you can consider starting a small dose and then up titrating as needed. And if the patient is about to be discharged, we want to try to simplify the regimen as much as possible. In terms of diet, I think we're all familiar with this. We want to try to focus on high fiber, lean protein, low glycemic index carbs, complex carbs, and we want to try to avoid simple sugars to prevent blood sugar fluctuations. Meal timing is very important, especially in patients with cognitive decline or dementia that are on insulin. Trying to maintain a standardized and structured routine would help reduce the risk of hypoglycemia, especially if they're on insulin or sulfonylureas. And then since older adults are at an increased risk of sarcopenia, then we want to encourage adequate protein intake to maintain muscle mass and function. Exercise in general should align with the individual's functional status and physical ability. Any movement is generally better than none. We can encourage seated or modified exercises to provide benefits for those with mobility limitations. But in general, a well-balanced diet, regular physical activity, and routine all contribute to stable blood sugars, muscle preservation, and overall well-being in older adults with diabetes. I think we have about 5 minutes to go over a couple of cases. I'll just read through them, uh, just just to deliver a couple more learning points. So we get a call from the nursing home. The resident has already received their insulin for breakfast, but is now nauseous and doesn't really want to eat. What should we advise the nurse to do? So since the insulin has already been injected and is being absorbed in the system, we want to try to feed the insulin. And since the patient is nauseous, we want to try to focus on like liquids hot with high simple sugars, ginger ale juice, a small snack of fruit. And then we want to advise the nurse to check the blood sugar every 15 to 30 minutes for up to 4 hours, which is when we expect the insulin to have washed away. Next resident is on 20 units of glargine every night, but is now NPO for a procedure the following day. Typically, we don't need to adjust the basal insulin, especially if it's an appropriate dose that doesn't cause them to get hypoglycemic. But if ever in doubt, I think it's better to be safe than sorry. So we would if you want to decrease the dose, typically you decrease it by 20%. Want to monitor more frequently for hypoglycemia, and you can also advise a bedtime snack to avoid hypoglycemia. The resident with a history of diabetes is on glipizide and basal. They have poor PO intake due to an infection. What adjustments would you make? And I think we'd all agree here that we want to stop the glipizide and monitor their blood sugars more frequently in that short period of time, like ACHS. And since we'd expect their blood sugars to be a little bit higher due to the physiological stress of the infection, you want to continue the basal insulin and then adjust it as needed. This last patient is on metformin. They're started on prednisone for a COPD exacerbation. Their blood sugar is now in the range of 280 to 350 during the day. What interventions would you consider making here? And what we could do is mostly encourage hydration, water, and avoiding simple carbs for the duration of the steroid course. You can consider starting a mealtime insulin like before lunch and before dinner, not necessarily before breakfast, because as I had mentioned earlier, if we're on prednisone, the most affected times of the day for hyperglycemia would be after lunchtime and after dinner time. If you want to avoid starting a scheduled insulin dose, you can consider a sliding scale correction just at in the evening before dinner and at bedtime. And then monitor and increase blood sugar checks for the duration of the prednisone course. So the key takeaways here, avoid overly aggressive blood glucose control in older adults. Hypoglycemia is very dangerous. Individualizing treatment based on patient's prognosis, kidney function, and appetite. Always want to check blood sugar before administering insulin. Focus on the correct timing and prevent hypoglycemia by adjusting meds for appetite and renal function. Thank you very much.
Yay! Outstanding, Dr. Kamal. So
Thank
I'll
you.
open it up to any questions. If anyone has a question, feel free to unmute and ask. And I will say, Jeanette said that you are amazing. Sarah Bradley said you did an excellent job. I saw some clapping from Jen Woodward and I think Anna Liggett and Abriella. So everyone thinks you're amazing and we're going to miss you
Thank you,
tremendously
everyone.
next year.
Oh, thank you. I'm going to miss you more. I can't wait to get all together next week.
It'll be fun. Yeah. Okay. And I'm just double checking. No questions. Okay. Have a good rest of the afternoon. Outstanding job. And make sure you put this on your CV. Yay.
Thank you. Bye.